Hello, guys. Happy to be with you for this second webinar. After the first, you can have on the SibUS-In, SibUS-In.com. And it's a great pleasure for me to welcome Mauricio Ceron. I'm sure that you begin to know Mauricio as the key dominant expert for Europe dedicated to ultrasound guide injections, and is now a very recognized international speaker. And he will give today two lectures you will discover just in a while. And I will present you the rest of the team of this webinar just in a few seconds. So let's begin. And I think it's important that we have some view about the numbers dedicated to the situation. The situation is critical. As you can see now, linked to the number of physicians and the population of the non-physician, we are about 400,000, 450,000 experts dedicated to all injections in our profession. But the point is that we have problems. And the problem is, of course, the vascular compromise, the necrosis, and the blindness. But I'm sure that you know how we are now concerning the situation. And it's very surprising to understand that among 100 to 150,000 vascular problems with or without necrosis appear per year, with a very surprising score. And more concerning the blindness. If you see now the evolution between 2019 2024, you can see that we are on a very not easy situation. So one of the big interesting point to save the situation is absolutely the ultrasound guidance. If you go back to the different alternative, I don't think that you will be very exciting concerning the potential, except the MRI. But MRI seems to be a little bit complicated. We are not going to send our patient on the daily practice for an MRI only for a mapping of the facial arteria, with not, I repeat, and we'll see just in a while, the real situation concerning the real life. One thing is very positive is that we have a very smart growing interest concerning the teaching activity in this segment for our profession. And we have many new publications, and you can discover our book after many other very interesting books with recently published. And of course, everything is staying at your disposal. Concerning the legalcy, we have another very interesting point you need to focus, is that concerning not the injectables we are accustomed to inject in the face, but concerning the fat grafting, look at that for the BBL with the injection of the buttock. It's now a law who ask any practitioner to make a documentation with ultrasound guidance before the injection in the buttock of the fat and during the injection of this fat BBL. So you can see now that it will be not unrealistic to estimate that for the face and for the injectable, the legalcy will follow. So it's quite important that you begin to be very keen to follow what's the evolution for your practice. Thanks to many good applications who have been provided by the company who are now on the lead of this activity for our profession. They give us, and Mauricio will comment that, a good level of analysis concerning the layer destined to HA injection or toxin injections. And I'm sure that you know more and more about that. So anatomy is now not only the real dissection 3D anatomy, but we have also to have the ultrasonic anatomy in our brain. We can detect any variation dedicated to the vessels, the muscles, and the pre-existing product. But we have a problem. We have a problem because the different heads are not exactly adapted. They don't come from our field, our injections. And the most part of the time, they are a little bit heavy, bulky, and a little bit big. We are going to describe you all tips and tricks about that. And last but not least, one of the more important points is that it's one of your hands is blocked. So it's not so easy to keep on acting as we are injecting every minute in our practice with the hands blocked. That's the reason we would like that to discover the product we are going to speak during the coming hour. So it's my pleasure to introduce the speaker. First, it will be Audrey Melin, elegant dermatologist from Paris, who is going to speak about the positioning you need to have with a real new method of injection that's adapted to your normal daily injections. Then Hugues Cartier, head of IMCAS for all dermatology and minimally invasive development, will speak about everything in direction of the filler. Then we are going to have Mauricio, that you will chat just in a while, who is going to speak about the same, dedicated to the toxin injections. Then we are going to have Sebastien Garson, who is the homologue of Hugues in direction of the surgery for IMCAS, the director of the program. We speak about a very new, interesting application about fat grafting with this new finger probe. And Mauricio will be back with the key point selecting ultrasound. And then we are going to have some interesting comment during the 5 remaining minutes from Kyo Yi, who is one of the key anatomists and medical practitioner from Seoul, Korea, dedicated to this development. So it's the time now to begin by Audrey Melin, who is going to speak about the SibUS method, Atlas of Dedicated Position.
So, hi everyone, my name is Audrey Melin. I'm thrilled to present you today in the SibUS method, the Atlas of Dedicated Position. Because as ultrasound is becoming increasingly integrated into aesthetic medicine, one of the most common questions we hear isn't just how to use a SibUS, but how to position yourself in order to use it with confidence, precision, and ease. So today I'm excited to share with you one key element that will determine the success of your SibUS-guided injections, which is your position. Not just where the probe sits, but how you sit, move, and align everything from your screen to your hands to your eyes. So we'll go through the essential ergonomic principles, tips for optimal posture, and small adjustments that will make a big difference into your daily practice, so that when you try SibUS yourself, it already feels natural. So let's start with something we don't emphasize enough in ultrasound-guided injections, which is ergonomics. It's not just about how to place the probe or how to operate the app. It's about how to position your body. Because if your wrist is tense, if your spine twisted, if the screen is off to the side, your image will become harder to interpret, your gestures will become awkward, and over time, fatigue or even injuries can set in. So this is why SibUS methods include an atlas of position, not just for the probe, but for your whole posture. Your chair, your hand, the screen, and the patient. The goal is really simple, just to create natural ergonomic flow where you can inject safely, visualize clearly, and protect your body. Because this is something you're going to do hundreds of times a month, and small adjustments will definitely make a huge difference. So how do we set up good posture? First, keep your wrist and elbow relaxed. Your wrist should float gently, never pressed or locked. Your non-injecting hand, the one wearing the SibUS, should always have a stable point of contact. This will ground your movement and give you better control over the injection. So you should always look for the most comfortable hand position. Don't hesitate to rest gently on the patient. It's perfectly fine to support your fingers, the lateral side of your hand, or even your forearm on the face or the chest of the patient. Then you want your visual line, a straight visual line. You want a straight, natural connection between your eyes, your hands, and the screen. So you need to place the screen either at the head of the patient or on the side, depending on your preferences and also on your room setup. So if you find yourself twisting your neck, you need to stop, adjust the screen placement and not your posture. Finally, think about your spine and your shoulders. Keep your spine natural and avoid raising one shoulder. To do so, you can ask the patient to turn the head or the body to give you better access. You can also lower the head of the chair so the patient is more reclined. Because when you use SibUS, you often wrap your scanning arm around the patient head in order to position the probe opposite to the cannula entry point. And if the patient is sitting too upright, this will forces you to lift your shoulder, especially when injecting the contralateral side. So this is where fatigue can set in. Having one shoulder constantly raised will disrupt your symmetry and comfort. So the key is really simple. Just lower the patient's head, recline the chair, and bring the body in a more horizontal position. This will allow your shoulders to remain at level and your posture to stay natural. So no tension, no strain, and no compensation. So these are small changes that will make a big difference in a daily comfort. So now let's look at how to position your body around the patient. You have two main strategies. Option one, stay on one side. You place the screen at the opposite side to keep your visual line straight. This method will minimize your own movement and keep your cable setup really simple. You almost don't move. Option two, you move around the patient. This is more dynamic and you change sides depending on the injection sites. So you place the SibUS probe and screen at the head of the patient to do so. And when you switch sides, you need to always pass behind the head to avoid twisting or pulling the cable. This method is more dynamic, and the advantage is that the patient doesn't need to move. You adapt instead. So both strategies work really well. You just need to choose the one that fits your habit and your room layout better. So the goal stays always the same: visual alignment, ergonomic postures, and minimal strain for both you and the patient. So once your body is in the right posture, let's talk about the probe itself. There are three main ways to position SibUS during an injection. Option one, in line with the cannula. So this will help you follow the path of your injection. Option two, opposite to the entry point. This will allow you to watch your cannula tip advance. And finally, perpendicular to the cannula or needle, of course, to see exactly where it's the end of the cannula or the needle and and the tissue that is surrounding it. So all three options are valid. You just need to choose the one that works best based on your preferences and on the injection zone. So now let's look at some practical example of how to position yourself with SibUS in real clinical scenarios. So we'll begin with toxin injections because they are often the easiest place to start. The great thing is, in most cases, neither your position nor the patient's position needs to change. So you can use SibUS exactly as you would during a standard toxin injection. Same gestures, same ergonomics. For instance, when treating the corrugator muscle, you can place the SibUS parallel to the muscle fibers. Then gently lift the muscle away from the orbital arcade, using either your thumb or your third finger. This will give you both the visibility and depth control for safe, precise, and toxin delivery. Here, for example, you can see how the probe is positioned during a typical injection of the procedures. You just observe the hand posture and how naturally it integrates into the movements. So these next image show real examples. So please pay attention to the angle of the probe and how it follows your usual injection line. You almost don't change anything. So what about hyaluronic acid injection? Well, when injecting, you have two ergonomic options. As we started to say earlier, you can either stay on the same side, typically on the right side, if you're right-handed, and ask the patient to rotate the head. The chariot will be placed at the left side of the patient in this scenario. So for injecting the patient right side, a slight turn to the left is usually enough, as you would do without using ultrasound. For injecting the patient left side, you need to ask for the patient to turn the head and sometimes even the upper body most significantly towards the right, so they can present the left side fully. This will give you the best access and keep your posture neutral. Or you can move around the patient, facing each side directly. But in that case, the patient remains neutral and you adapt your own position. The chariot to do so is placed at the head of the patient, and when you move, you just need to pass behind the patient's head. In both cases, you can place the probe in line with the cannula, opposite or perpendicular. This simple principle is really easy to be applied and can be applied in all the zones. So let's apply them to hyaluronic acid injection so you can see. So for example, for treating the tear trough, here is an example of how SibUS integrates really seamlessly into a tear trough injection. Notice the alignment between the probe and the cannula, whether the probe is perpendicular or in line with the cannula. So for the naviolnasal fold, we follow the same ergonomic principles as for the tear trough. So you can either stay on the same side and ask the patient to rotate the head and body accordingly, or move around the patient depending on your preferences and on the room setup. The probe can be placed either in line or opposite to the cannula based on what gives you the best visibility and control. So what about mid-face? Well, for mid-face injection, as always, either stay on one side and ask the patient to rotate the head and torso or move around the table. Place the probe either in line or perpendicular or opposite to the cannula or needle, depending on which gives you the best visibility and comfort. This time, for example, with the probe in line with the cannula. So please observe how the hand holds remain natural and stable with good support and clear visual line, whether it's perpendicular or opposite or in line with the cannula. So as mentioned, for mandibular line, masseter, and chin injection, it's always the same principle, either stay on one side or rotate around the patients. The proposition is, as always, the same. So in the chin and in the mandibular area, position remains intuitive. What changing slightly is your hand support and angulation sometimes. So you can see here for this type of injection, you can either place it in line, opposite, or perpendicular, depending on what you prefer and how you see the most clearly during the injection. The same thing for the chin, either with a needle or with a cannula. Lastly, for the temple region, same approach again. Fixed position or moving around, depending on your preference. Choose a proposition that offers the best view of your cannula pass. The probe positioning follows the same principle. It's all about finding the best angle for a comfortable injection. Here is the last example, and you can see for the temple injection, only the patient moves. My hands actually stay exactly the same, and just the patient will rotate his upper body and torso just to the right, so he can give me full access to the left side. So it's really easy to integrate. So here are the key takeaways for a comfortable and confident use of SibUS. First, your position comes first before the device. It's a really easy to use device, so it will really seamlessly integrate into your daily injection. You can follow simple, repeatable ergonomic setups. Either stay on one side or move around the patient, and the chariot position will just depend on that. If you stay on one side, you put the chariot at the opposite side, and if you prefer to move around the patient, you can put the chariot and the screen at the head of the patient. You can ask for the patient to move its posture to avoid fatigue for you, since you are doing repeated type of injections. You can choose a probe and the probe position depending on on the side that you will inject and on how you will see the cannula move. So with the right positioning, SibUS will become a second nature, and it will be really easy to integrate it in your day-to-day practice. So thank you very much. If you have any questions, please don't hesitate.
Well, so I think it's a very important point concerning the first lecture, because guys, it's not something which is very difficult. Of course, we are going to speak about the learning curve, but the learning curve is not so big. And I would like to have the point of view of Mauricio concerning the fact that he was very dedicated to have this hands block with one hand, and he was teaching and exercising during years and years with that, and how now he feel comfortable concerning the fact that he has to inject with the two hands and this little probe on the finger of the tip. So how to play with that, Mauricio?
Yes. So I think it's something very easy to use, and something that Audrey said is really fundamental, the ergonomics. Ergonomics make it so easy. So if you plan your injection in order to do it the easiest way, then using the finger probe will be even easier. So you will be able to use your rest fingers of your hand to lift the tissue, to stretch the tissue, and you just even sometimes forget that you have this finger probe in your hand because it's really light. It is not bulky, it is not heavy, it doesn't cause any fatigue. So you just use it with your finger. It's very important that you use your hand like a little, I always say it's like a little spider position. So you don't do like this, because people tend to sometimes over tense the finger. So you use it like a little spider to use your finger probe to place it on the skin. You just check where you are. Don't matter what you're injecting. You see that you're in the right layer, and then you go and inject.
Perfect. Hugues. So let me introduce Hugues. We spoke, of course, of Hugues just before this lecture. So Hugues is one of our dedicated experts. I think you are mute, Hugues, for the moment. Yes, now you are open. And we are happy, of course, to have you on board. And it's a very important point that you give your feeling about, is it difficult to switch from the classic block hand with this probe and to go to this approach with the little finger probe? So what is your feeling about that?
If you use a classic platform, classic hand pace, it could be more difficult because you need to change your mind. You need to change how to handle hand pace if you do echo guide procedure with the classic probes. But really, if you are not so lazy and you really feel in confidence with this kind of new device, a rupture device for us, really, it's not take a long time, because the most difficult is what you want, what you expect from this device. If you want to make a clinical trials, if you want to make a publication, if you want to stay on to sleep with your D platform, okay, buy the platform. This fine is to be pragmatic, to be practical. Is no need to take time to use it in a daily practice. The most important, this device was created for a classic injector, not for a superficial. Exactly for the same as radiologist or gynecologist. You have sometimes some colleagues, they are very hyper specialist of many area, and you send it to this specialist, like Ximena, by example. I've no Ximena,
Ximena Morsman.
You put any device in her hands, she can use it. But I'm not Ximena. I'm just dermatologist. I want to use something very easy to use, not to complicate the life of my patient, because sometimes patients are a little afraid by the device. When you have a big device really on your face with a lot of gel, it's uncomfortable for the patient. So the most important is that. So if you can say to your patient, it's just to check before, after, or during injection, because it's not necessary to use at any time for echo guide procedure. You can use when you want, because you have the possibility to have.
Yeah, but
you can keep your finger. When you start your patient, you put the finger. If you need, you use. If you don't need, you don't need. But you have the finger is no place. It don't take place. It's all on your finger. So use when you want. When you have a classic platform, you have to put on the platform. You have to open the platform. It's so more difficult. And to you take more time on patient, little oxygen. When you do some injectable to patient, there are little oxygen by injection. With that, no, it's like your hand. Patient feel nothing. And most important, you don't need a lot of gel on your face.
Yes.
Imagine when you have a lot of gel because you have a big handpiece, very patients are unhappy. Okay, with that. So to fix your finger when you have a lot of gel on face, it's difficult because your finger glide on the face. With SibUS, is really no need to use a lot of gel. It's very important because it's a very small handpiece, so very very precise.
So Hugues, we need to be on time, and we are going to chat just after your lecture. So it's my pleasure to invite you to have this lecture during 12-minute demonstration with video of filler injection with SibUS.
Okay, I try to share probably some trouble, but I hope it will work. Partager mon écran. Ok, diffusion, lancer la diffusion. Ok. Do you see my screen?
Yes,
okay,
absolutely.
Bon. I don't know why it doesn't work, but okay, I will do that like that and you will see. The diaporama doesn't work. I don't know why. Okay, but no, never mind. Most important is easy to use to understand that the SibUS, it's a finger probe. You put that on your finger, okay? It is small. It doesn't take place because you have classic linear curved probes, okay, stick for finger. At the beginning, it was for fingers, okay? But this, fine, follow your finger. So very easy. About the 15 megahertz. 15 megahertz is very important. The best, we can say it 12 or 15 or 18 or 20, 22, but the most important is the traduction of the probe see on the the device inside to treat the data. And the most important for us, with this 15 megahertz, is the same as like 18. So for us, for skin doctor, is enough. For surgeon, is enough because you have enough depth to penetrate in the skin and in the fat until the bone, until really 5 to 6 centimeters. That means it's really enough, but you can stay very superficially as you want or when you want. Which ultrasound you can use? You know, in my clinic, my colleagues use the same. When we start at the beginning, because I'm dermatologist, but also phlebologist. So I use more than 25 years probes, but it was not adapted because my probe was 7.5 megahertz, so it was not enough precise for superficial disease or skin condition. But when you look at these probes from different laboratory, you can see that it's not adapted. Sometimes it's too small, sometimes it's unadapted, sometimes you need 2 hands, sometimes another, you need help with an assistant to catch the probes, to maintain the probes, to inject. So really, it's easy to understand that really sometimes is most important. About the anatomy, you know, I'm just dermatologist. I'm not Sebastien, I'm not Benjamin, I'm not Dr. Fana, I don't care about anatomy. What I want to see with this device, I want to see the different pattern. I want to see the fat, the muscle, veins, arteria, and bone on that set. And I want to see, because I inject since so many years, I can evaluate and estimate when I introduce my needle and my cannula, where I am. But with the SibUS, I can see really where I am. It's the most important. And to avoid any troubles. Contact to the bone is easy. Anybody, no need to use ultrasound to touch the bone. But want to stay maybe in a superficial fat, just below, in contact to the vein, superficial vein. But if I want to go further, if I don't want to reach the bone, and you will see maybe this slide with echography, you see the curve of the bone. Most of the time, you want to inject like a shotgun or gunshot injection. And sometimes you are unhappy and you are unlucky because you have exactly the point you want to inject in contact with bone. You have a deep facial temporal arteria. and you are unlucky if you inject directly. With the probes, you put your finger, just localize where you want to, and you see nothing, you can inject. You see something, you don't inject. And you take another procedure to inject by cannula, or you avoid any gunshot procedure because it's too dangerous in your hand. Exactly the same for temples. If you are very superficially, do we need probes, SibUS? Yes or not? Why? Maybe sometime when you inject your cannula too superficially above the superficial in the fat just below the skin, sometimes you have some vessel, okay? And sometimes it's difficult to penetrate. With the probe, you put your finger, you see some vein. Okay, you avoid. Okay, you contour and you go further or deeper, or maybe superficially, you avoid bruising. Okay, if you want to go deeper, it's more necessary to use ultrasound, but to be superficially, you want to see what you want, you just put out your finger and you see where you are, because you don't need a lot of gels, so you can see immediately where you want. So some colleagues say it's impossible to use ultrasound on a procedure, on injection procedure. Yes, you can do it. You are just to move your finger to see where you want. So really, it's easy. It's not so easy to put your finger on the table, take your probes again, and push the probes, and to calculate. Really, with your finger, just this small hand piece. So very, very easy. So you can see many things. You can stay superficial, you can deep, you can see some vessels, some atria, because you have the Doppler mode, okay? Like my colleague, Dr. Wang Li, he can show you, really, you see immediately, you see the vessel. It's so easy for us. And you can see the different depths. You can see the skin, the superficial tissue with the arterial cutis. You can see the muscle. You can see the ligament. The ligament is not so easy. You need to be a very good practitioner. But with the finger, when you introduce, you can see, so if you have some resistance, maybe you mean that you are in ligament. Okay, you can check with your finger probes, and you see the ligament. You see you are in the right place, and you avoid to inject below or inside. You should have the choice. You have the most important, the possibility to decide where you want to inject. It's the most important for this area. It's so tricky. Is it a problem of vascular probe? Is it a problem of vascular complication? No, it's just a problem of where is the artery. Where is the artery? Is it contact to the bone? Really, if you want, inject very superficially, like a blanching technique. You can do it, but you check with your finger probes. You don't see any vessel superficially, no angiosome, and you can inject. But if you want to inject deeper, everybody knows it's dangerous. So don't take any risk to inject deeper. Everybody knows that. But with this kind of probes, you can see really where you want, and you see the supraarticular artery, the angular artery is not so difficult. For my colleague from Korea, Pugh, Lee Won, or some colleague from Europe on other conditions. So easy to use, okay? You need to learn how to use it, and I will show you, okay? You have the probes. Alors, I do normally, I'm not in this position because it's difficult for me to take my face back, but you will see I inject toxin really on my finger probes, help me to avoid any diffusion. That means I check where is the muscle. Sometimes patient has to move the muscle. I inject and I press gently with my probes, like a finger, to avoid any diffusion of the toxin. So your probes can help you, and you will see, can help you to avoid any diffusion, because I push and I am in the muscle very close, and I see where I am directly, and I see the spray of the toxin in this area. Why? Because maybe you can be more reproducible, you can be more efficient, and you can spare a unit of toxin. We see so many conditions of in this glabellar zone. Last 1 month ago with Benjamin, we show some different possibilities how to inject. Okay, V shape, U shape, Y shape, many. Okay, with the probes, you see the muscle, and we are very surprising because Itikim and his friend, colleagues, they published 2 years ago that sometimes in 15% is unnecessary to inject in the procerus because it don't move. It was just the lower part of the forehead move. So it's unnecessary to inject. Or sometimes, more and more, I inject only 3 points in the glabellar zone, but I do with a retrograde injection. That means it looks like 5, but it's only 3 because I can follow the needle on the spray with the probes, and I say that I'm really only in the muscle. So easy. And for this area, really, when I begin to inject, the first thing I learned is to inject the nasolabial fold. Really, we are completely crazy because it's probably the most difficult and most dangerous area when you see the different map of vessel facial arteria, and not only arteria, but also vein. Sometimes we have some colleagues inject a lot of product in the venous, and we find in the cavernous sinus a lot of hyaluronic acid. And he inject in the vein. He catheterized the vein. It was not arteria. So he can avoid facial arteria on his branch, but also some vein. So it's very interesting, and it's not easy. We know that the color is not blue and red because it's a blood flow, but it's important to see, be aware you have vessel. Really, sometimes I don't care if it's arterial or vein. I want to see that I need to avoid this area. And you will see the cannula just above, maybe 1 or 2 millimeters close from the vessel. And you see the movement of the cannula very close, but you are safe. And you cannot say to patient and to other doctors that you can do it exactly the same as us if you use the SibUS to be so precise, and you can avoid with this new procedure some blind technique. Okay, exactly the same. Facial arteria, nasolabial. In a gunshot, you will see deep fat, the curve of the bone, and you see some vessel angiosoma superficially. You can inject directly in contact to the bone. Okay, and you are more safe to inject because you have no. But if you have in contact to the bone some branch of a facial arterial, don't inject in that way. You say no, I don't inject because it's too dangerous, and it's very, very easy to do it. Exactly the same with Lino Schelke, because now we have a staff for the jugal malar, exactly the same. It's most important which area we are. We are exactly in the same. I will show up. I will show this area is so tricky area where you want to inject in the jugal malar, in the mediofacial fold. You need to check where is the infraorbital artery, where are the vein, where are maybe the deep fat, where are the muscle, where is the zygomatic major. Sometimes you find some resistance. Sometimes you can also avoid when you want to inject some migration of product with this picture done by Sebastien Garson. You will see where you want to be is the most important. And I will show you this. Hop, et là je vais démarrer. You see some technique with the procedure, probes in a hand, left hand, inject, and I will see, and I can do with a gunshot directly in the top of the cheek, and I check immediately where I put my C, and you will see a big difference when you inject with a cannula. You have retrograde migrations most of the time, less with needle, and sometimes you need to move your needle because the hole of the needle can spray the product where you want. So sometimes I do a circle with my cannula, and you don't see black technique. You can say yes, but if you want to see, you remove your finger and you see what's the result immediately. What's happened? You check at any time when you want. If not, it's not an obligation to use it at any time, but it's so easy to check. So for us, it's very, very interesting to use in depression. And we see the patient just after, before and after, with only 2 injections. So
we need to stay on time a little bit, Hugues. If you can just a little bit.
I just finished.
Yes.
Exactly the same for the same area, the same cannula, the masseter, these probes. Sometimes we are very surprising, but we see a lot of product inside the parotid on the masseter muscle with fillers, and it's not the choice of the patient and the doctor. So you can check and to stay really in the subfascia to be sure that you don't inject deeply to avoid any complication. Exactly the same. So with this device, you have many possibilities. You have touch screen, you have high precision, you have multiple possibility of imaging, and you can record and store at anyone. And you have a small luggage, and you can take in a clinic, in your congress, anywhere you want. So with the SibUS, it's really easy to handle. And for the future, you will have new echographic needle and cannula. And for me, it's not a point between the cannula. We see a lot of battle between needle and cannula, but really, with SibUS, you can make the right choice. It's the most important. So for us, we have a lot of future development with this device, and we will show you a lot of things, how to inject, to check very easily on how long does it take for the peripherum, for toxins. Most interesting, I love the presentation of Mauricio because it's so tricky for muscle. So for us, just to to conclude, it's the ultimate finger probes. You stay tactile and free. You check vascular pattern at any time. You check previous injections, threads, and disease, any derm disease. You can track fillers over time and immediately, and you can find the right place to inject toxin in the muscle. Thank you.
Perfect. So we'll chat a little bit just after now the first lecture of Mauricio. So Mauricio, it's your turn. You will speak about demonstration with video of toxin injection of SibUS.
Okay, there you go. I will try. So, can you hear me now?
Yes.
And can you see the screen in full screen? All
yes,
right.
absolutely.
So, hello everybody, and thank you so much. And I am really happy to be part of this incredible journey with SibUS. And I'm gonna take you guys on a journey on how to approach facial muscles in order to apply neurotoxins. And here's the thing, we all really enjoy injecting neurotoxins, right? Until we don't. So you see here different complications all around the face, in the upper face, in the lower face. And we know that this is not a thing about the toxin. Sometimes we blame it on the toxin, but it's the technique, because the toxin does its work. It relaxes muscles. So it is important to know that our technique is fundamental in order to avoid complications. So I am very happy to be part of different companies dedicated to ultrasound-based research and also ultrasound training for facial aesthetics, next to incredible minds in the field. And we know that ultrasound plays an important role in aesthetic medicine, not only at the moment of application of fillers or complications management, but also in order to understand the anatomy of the face and the dynamics. And this talk right now is about neurotoxins. It's the fine art. So this is something we can actually improve even more. We know that neurotoxins and the market of the neurotoxins, it's incredible. And it's estimated to experience even more growth. By 2028, we expect it to grow in both the medical and the aesthetic application into impressive 10.5 billions. So botulinum toxin is still the most requested treatment around the world. And our duty as practitioners is to apply and to offer these treatments as safe as possible and as precise as possible and as effective as possible. And let me just continue. We have different technologies. This is a little bit of the journey of ultrasound. If we go back in time where those machines were pretty big and complex, we have now more, of course, these high-end devices that allowed us many different perspectives on the anatomy. Then the handheld or wireless device came into the market and it was a revolution. But now we have, as we know, the power in the tip of our finger. And that's so practical. Now, when you ask yourself, Mauricio, where's actually the evidence on neurotoxins and ultrasound and the guidance? Well, we know this from neurology, and you have here different, very relevant publications actually dedicated to this topic. And this covers all of the facial muscles that we can inject. And in summary, this literature summary demonstrates that using ultrasound when we apply neurotoxins just allowed us to be more precise and more targeted. And with that, also safer, and more efficient. So there is actually no way to work more targeted than this. Now, let's just go through the injection process of a patient. This is a beautiful lady from the Philippines, and she is asking to reduce her facial hyperdynamic, those vectors that pull down. So we're going to perform here a full face treatment using the new version of the SibUS, which is this very nice screen of 23, 24 inches touch technique. And we're going to cover the glabella, the orbicularis oculi, the DAO, the mentalis muscle, and I'm going to talk a little bit about the masseter. And we have here the opportunity to use a finger probe that is curved, so adapting to different areas of the face, concavities, convexities, and just to have a very light device on our finger makes everything so much easier. Now, if we go to the frontalis and we have a little bit of a look into the anatomy, I am placing my probe horizontally, and you see here perfectly where the tissue is, and you see here the muscle. We're chasing facial muscles, and muscles look hypoechoic, they are dynamic, and they are band-like structures. You see here the frontalis muscle. Here's in the contraction. And when the frontalis contracts, you can see that it bulges a little bit more. And here it is, when it is contracting, you see even the suprafrontalis and the subfrontalis fascia. If we change the position of the probe, we have here the vertical position. You see here beautiful the bone structure and how the muscle pulls up, and you see here the wrinkles and how the subcutaneous fat is bulging up. This is not the muscle, this is the fat. The muscle is much deeper. And when I approach the frontalis, I am not doing this in this patient because of obvious reasons and of her anatomy, but this is another example. This is a male patient. Here is my needle. I am approaching the muscle, and you can perfectly see in this out-of-plane approach how I can inject my 1 to 2 units of botulinum toxin. Here I am intramuscular. Now, going to the glabella, this is a very interesting prospective and randomized study that could demonstrate on patients that the botulinum toxin injection using ultrasound has a quicker onset of action and also having better final outcomes for the patient. So pretty interesting, and why not? Here I am having a look into the procerus muscle. Of course, you see it here contracting. Here's the subcutaneous fat. You see all of the layers from the epidermis through the dermis down to the bone. And if we go and have a look into the corrugator superciliary muscle, it is a little deeper, and you see it here. Hypoechoic band-like structure. You see here also the supratrochlear foramen, and this is the other side. Have a look into how I am using and placing my hand in order to make that muscles visible and in order to see the dynamics. Now, if I want to inject the procerus, I am having a little bit of a change here in comparison to what Audrey showed before. I am placing my probe, I am using my probe with my non-injecting hands, and I am placing it vertically, and I'm coming from upwards. So you can see my needle, here it is, and I am in the muscle. I see the indirect movement that I am placing my botulinum toxin in a 1-to-1 dilution, and I am here performing a 3-point glabellar injection. Here's the needle, here I am in the muscle, you see it perfectly, here is the tip of it, and then you see that my inoculation, like here, is intramuscular. So I am using here normally 3 to 4 units per each injection point in a 1-to-1 dilution, again, in a in-plane injection technique. In-plane means that you see the needle along the long axis of the probe. Now the orbicularis oculi, we have different concepts on this, and this is one of the newest publications on the ultrasound guidance on the orbicularis oculi. And you see again a band-like structure, hypoechoic. Look at how I'm placing my probe, and it is contracting exactly there. If you want to keep your treatment very subtle and you don't want to make it too strong, you go subdermally, like here. You're above the muscle. and you inject your 1 to 2, sometimes maybe 3 units of botulinum toxin, depending on what you want to achieve. So the recommendations, according to these publications, is to work subdermally in order to not paralyze the muscle too much so that it doesn't look so unnatural, or even to prevent more lymphatic issues in the patients. We know that this might also cause a problem when we treat mature patients as well. Now, moving down to the lower phase. And this is something I really enjoy because it's so rewarding. Now, I am placing my probe again in a vertical position. You see here my DAO muscle, and here is below the DAO, the DLI. You see the bone. You see also that interruption between the bone lines, which is the mental foramen, which of course has the neurovascular bundle there. And I come in again in a inline injection technique. You see, here's my needle. I go below, I am inside the muscle, and I inject 1 to 2 units of a 1-to-1 dilution of botulinum toxin. You see here, next to this presentations, a little bit of the evidence that we have out there in the literature. The mentalis muscle is also pretty easy to recognize. Hypoechoic, bent-like structure. It comes from deep. It has muscle fibers that insert in the dermis and pulls up the chin upwards. And when I chase that muscle, you see again here perfectly, I am here coming from below, again in an inline injection technique. And when I am in the muscle, you see here, I am coming with my needle. And this needle is going to reach these areas where I am going to inject later my botulinum toxins. So it's not so difficult, to be honest. And now the masseter. Actually, the masseter deserves a separate lecture because this muscle is very complex. And we can also have complications here. We know that the masseter has a deep inferior tendon, and that deep inferior tendon is different on every one of us. We have different patterns, and this has been also demonstrated. And this muscle also has different bellies that also have different dynamics. So in order to have a better assessment, it's so much easier to use an ultrasound, check the areas where the muscle has to be injected, and then do your injection. Sometimes we have patients that also lack efficacy because they have repeated injections of botulinum toxin and the muscle echogenicity changes, and we are repeating injections in non-functional parts. You can identify in your ultrasound examination which parts of the muscles are still working fine or even compensating, and the areas that are not working. Because we know that repeated botulinum toxin injections to the masseter might cause fibrosis, atrophy, or problems like that. So as for the masseter, I think this was enough for now. And now let's have a look to the patient. Here's the patient before, here's the patient after, and this is just after 3 days of the treatment. The onset has been pretty fast, and you can see clearly that the patient cannot even frown anymore so much. In the lower phase, I'm still expecting a little bit more of an effect, but it's really easy and fast how you see your results. And now to finish this, my take-home messages regarding neurotoxin injections with ultrasound guidance. It makes it more precise, and with that safer. You're gonna be able to visualize the key structures, and also, of course, tailor those treatments according to the anatomy of your patients, and you will have better results. And with that, I mean a faster wrinkle reduction, a precise muscle targeting, and also happier patients. And I think I am done with that. Yes. I thank you so much, and I am open for all of your questions.
Please, Guy, please, we would like to have your question. So please go to the Q&R, and it's open, and we would like to answer to your question. You are a nice community today with us, so we are very happy about that. So it's a time for you to react, and we would be so happy for that. So now it's time to welcome Sebastien Garson, and he will speak during 12 minutes about demonstration with video of SibUS for fat grafting and body indication.
So, dear friend, dear colleague, it's a pleasure to be with you today for this new webinar SibUS, and let's talk about ultrasound in plastic surgery and body contouring. What SibUS means for breast and body and ultrasound. So my conflict of interest on this topic, I'm consultant for SibUS. So ultrasound, for sure now we understand that even in plastic surgery it's a game changer. Since at the beginning was quite difficult and less affordable to have a huge platform of ultrasound in our practice, but it became more compact by time, cheapest, and becoming wireless. But was it really helpful and adapt for our practice? That's the second question. So if you're interested for the ultrasound, what makes sense for me at the beginning when I start to understand how it works, that you have different kind of frequency on the probe, and this frequency allow you to see clearly different kind of thickness of tissue. Less frequency you get, more thickness you are able to go through, and with high frequency you are able to see exactly not so far under the skin. But in the other hand, the quality of the image you can get will be more important with the biggest frequency. So higher the frequency is, biggest is the quality of the image, more it's accurate, but less deep you are in fact. So for the plastic surgery range, it's around 15 megahertz. That's pretty cool and well adapted, like a Swiss knife in our practice. So for the anatomy and ultrasound, let's talk about, for example, in the breast, in the décolleté. In this part of the anatomy, it's really interesting because you're able to visualize a different plane. Just below the skin, where you find the fat, superficial fat, the Cooper ligament, and that's the parenchyma, and of course the muscle. On the top, the pectoralis major in the décolleté, and below the pectoralis minor. You can see easily that some image in white with some shadow below. This is due to the bone who make a shadow and block the wave of the ultrasound. So you have no image at all behind due to that. So when you get that, it's bone and the shadow below. So this is the costal arch, in fact. For the breast, again, so you're able to see clearly what is going on since the skin there, more black the fatty tissue, and in more whitish gray the parenchyma, the glandular scaffold, and below of it, of course, you're going to find the muscle with its fiber. So it's a dynamic exam, so it's really interesting to contract some muscle. It's okay for the breast, it's okay for the face, it's okay for everywhere in order to have a clear vision and a good accuracy of your exam in order to see exactly where you are and what you are looking for. So you see in this patient, she gets some breast implant, and you're able to see in live really the contraction of the pec major, all the wave made on the shell of the implant. So it's really interesting and very helpful in order to compare and check the quality of your implant, for example, in this kind of indication. For the buttock, gluteus maximus is a very tough muscle, and we know this region is involved more and more in terms of treatment, from the polylactic acid up to the HA, and of course the fat transfer. But there's some safety issue regarding all this injection, so you have to pay attention and visualize the limit between the skin and the muscle, the gluteus maximus, because below that is not mandatory to inject. And for the abdomen is interesting, of course, because you're able to visualize the relationship between the muscle wall of the rectus abdominis, and of course there's any hernia, any problem on this region on the linea alba, and you're able to visualize all the relationship in the superficialis fascia of this region, as you can see there, between the superficial fat layer and the deep fat layer of the abdomen. So with the Doppler mode, it's really interesting for all the surgery of microsurgery, because you're able to visualize exactly where are the perforator. For example, for the DIEP perforator, you're able to follow the where the flow is of the vessel and visualize the area where the most efficient perfusion is, for the skin paddle you're going to use for the breast reconstruction. So application, so for the exam, this kind of inguinal mass. In that exam, we get this kind of image, very heterogeneous inside, but well defined outside. But in fact, it was a diaphragm dermatofibrosarcoma for this kind of cyst. Nothing special, but it allowed you to know how is the length of your epidermal cyst, for example. More interesting is the diagnose, especially this kind of patient. She get previously, many years before, 3 years before, some injection of HA in the buttock in order to restore some volume, but she still feel something when you touch, and you're able to visualize even without not touching the butt. And you see at the exam we have some lumps of HA still, even it's 3 years after the injection. So you are able to diagnose the type of product used for her. So this is super cool, but you understand also that the HA is very just under the dermis for this one, for example. But also you're able to see that we have a very thin coverage between the skin up to the muscle. So it's going to be tricky to for the treatment after that. So in video you see the different kind of lump. The problem for her, if you visualize, we have some lump in the fat, okay, but we have in the muscle too. Lump in the muscle, lump in the muscle, in the fat, in the muscle. So in fact, the doctor who made this injection at the time put the HA everywhere, even in the muscle. So that's why it could be very dangerous for the safety of the patient. And you can see on the Doppler mode, sometimes you have some lumps, but with some image like a septi between, but in fact the lump is around the perforator. So if you put a needle in for urinase, you can get some hematoma for sure. Vascular mapping for DIEP, already seen. This is Professor Sina using it routinely and able to make some free flap for any kind of surgery. So very efficient, and everything has been published. And for example, the fascia lata free flap also, it's useful to visualize all the perforator. For fat grafting, of course, it's quite interesting. This is a case of transgender patient who needs some definition of the pectoralis major. So some fat grafting in the pec major is done actually, and under control, of course, of the ultrasound, because you see there, this is a costal arch of the bone. You see there the cannula. You see the space with the muscle, intercostal muscle, below the heart, pumping right now, and you see how is closed the cannula instead is plain. So you can be in trouble very easily if you don't pay attention to. And the interesting thing is how you see the fat colonize all the septi of the muscle, of the fiber of the muscle when you are doing your fat grafting. So this is very interesting. Sorry, that's another case. So another case with a SibUS system, because in this lady she gets a problem of abdominal hernia. So, but anyway, we need for her to arrest some fat. So regarding the image with the ultrasound, we were able to visualize where are the issue of the hernia of the abdominal wall in order to avoid any injury of this region. So the same case for this lady, and you see there that's post-reconstruction right breast. She gets an implant below, as you can see, and you see the image with my cannula right there, and you see in white in live like a light string. This is the fat, in fact, with the interference, where the fat is running when I do my fat transfer in this region. So you see there's not a big space between the skin up to the shell of the implant and the capsula, but looking on live with the ultrasound, you are able to visualize clearly where are the cannula, if you are on the top of it, if you are in the middle, or if you are close to the capsula. And doing so, you are safe and you won't injure your implant in this case. For the butt, as I mentioned already, in the case, it's really important to avoid any injection in the muscle. So using your ultrasound in this indication is really important, and you see there the cannula, so I'm very in the superficial space, and again you see when I graft backward gentle my fat grafting, you see clearly the fat running in live in the tissue, in the depth of the tissue. So it changed the way you are imaging the way you are fat grafting anyway, because you were thinking everything was staying into the tunnel, and in fact it doesn't stay really inside the tunnel you preform. The fat spray in some way over the tissue, over the tunnel you have preformed. But anyway, it's really important to visualize where you cannula in order to avoid as much as possible the danger zone. For control, it's fantastic because you're able, this is HA injection, it's a patient of mine that do the injection, but she gets a long time ago some liposuction in this region, and she wants to recover some volume for it, but she gets some palpation. But even it's me, the product gave some lump anyway, even you try to have made the best positionment of the HA in this region, and you're able to visualize these lumps and control the size with the time running, of course, by the follow-up. For breast, it's perfect because sometimes some patient can complain, my breast after my surgery blow up, and you have to check. In this case, mastopexy plus implant is necessary to inspect you don't have any seroma. And for her, the exam was clear. There was no seroma around the capsula. So we can be very clear with the patient. Everything is normal, it's just inflammation. Nothing special to do for her, just wait. For a case of post-hematoma on abdominoplasty, so you can see in live you're able to make your aspiration in order to reduce this seroma post-hematoma in this region. So it's very accurate and very easy under the control of the ultrasound to erase this small seroma. So SibUS, ultrasound was a game changer, and SibUS definitely is a second game changer in our practice. Why? Because the idea was to make it the extension of your practice, the extension of your finger, so to make it easy and comfortable for the time you're using it at the OR. For example, when you use it as it's not wireless, there's no heating process, because when you are using a probe, classical probe, more you use it, more this probe gonna be heating, and it could be very uncomfortable at the end. Also, the classical probe will get some battery in it. They have some weight, so if you use it 100%, it's weight, and it's not comfortable using it all the time. And of course, if you have a battery, you have a limit of time. So if your surgery taking a lot of time, more than your battery, of course you will be in trouble in terms of autonomy of it. So you have not this limit of using. So the idea is you can use it like that under the protection, like this. You put the protection in your finger in, easy. or you can use it and protect only the cable put on the tip of your first glove, and you put of course some gel in order to transmit the ultrasound echo, and you put the second glove over. By the way, it's very natural. It's not you don't have any conflict with your hand, and this allows to keep all the surgery long the probe in this position. So as you can see, it's directly in the same way of your finger. It doesn't change the way you are dealing. You can able to use the other finger of your hand even for making some liposuction, as you can be there with my left hand. It's not a problem. You're able to grab a forceps for making your incision, as you can see there, in order to get a clear vision of the capsula in that case. So you will stay with it all the surgery long with no problem. And you're able even to grab the forceps and make your stitches with it at the end. So it's not a problem. It's compatible with all the surgery. So just to conclude, because you need, webinar is great, but hands-on is better, especially for ultrasound. So we invite you for the next 24th of Saturday of May for the hands-on class of SibUS in Paris for clinic thinking. So thank you very much for the attention, and I hope you enjoy your webinar. See you.
So I think we are going now to invite Mauricio. So it's your time concerning a very interesting lecture. We finalize this webinar. Keep on selecting ultrasound-guided injection device.
Yes. So it's clearly also important that not only for aesthetic reasons or aesthetic injections, this is going to be something helpful, but also in surgical things, right? And if I just move a little bit my things in order to see everything. So I'm going to start now. This is also something that is very important, and I hope that I can give you a little bit of a shed of light into when you want to decide what to do when it comes to the decision of what kind of an ultrasound device you buy. Now we're talking about ultrasound-guided injections. And let me just move to this side. I don't think my presentation is working. Oh, now it's working. Sometimes we can feel really overwhelmed when we just try to decide what to use and we don't know what to do. Sometimes it's a matter of money, matter of, there are so many different factors that keep people like a little in fear of using ultrasound. And we have here out actually different kind of devices. We have the portable devices, we have the mid-range devices, we have the handheld devices, and we now have actually a new category on this kind of devices because there is nothing else comparable in the market like the finger probe. And I'm going to walk you through the pros and contrasts on all of these different kind of devices and present you what you can do. Now, if we have a look into these images, here the probe is in a vertical position on the deep piriform space. And we see that all of those images are actually pretty comparable, right? You see the dermis, you see the deep fat, you see the bone, and those are different probes. We have here a high end, a mid-range, a handheld device, and we have here our SibUS device that really demonstrates to have a very good image resolution. Look at that beautiful, well-defined, crispy bony line that it gives us. And with this finger probe, which again contains 15 megahertz, which is more than enough, you have also the possibility to use a Doppler mode. This is, again, one handheld device, 10 megahertz, mid-end device, 20 megahertz. I'm also used to work with this one. And of course, the SibUS, which gives you a beautiful image of the vasculature also in the deep piriform space. This is another example of a high-end device that even allows you to do some kind of 3D images. But when it comes to deciding what device you want to use, it's actually 4 different points, and I'm gonna walk you through this. First is your main objective. What do you want to do with that device? Are you an aesthetic physician and injector? You want to recognize layers and to place your filler more precise, do ultrasound-guided injections to dissolve even, or even do vascular mapping prior to that, then you will be in the range of something between 15 to 20 megahertz easier. If you're a dermatologist and if you perform research, if you focus on more superficial indications into inflammatory diseases or even tumors, then those high-end devices offering higher frequencies will be actually the way to go. But we're talking about aesthetic injections, right? So these high-end devices, they have, of course, bigger screens, very sophisticated images, and a better actual spatial resolution and Doppler sensitivity and much more. But the thing is, of course, those prices are very high. You can even pay over 100,000 euros here in Germany, or even more, for one of those devices. And those are not so easy to move. So there is no easy portability with those devices. Then we have the mid-range devices, the ones that I also usually, I am used to work with those. They also have bigger screens. You can use multiple probes. They have also very good softwares and have a longer battery duration between 1 to 4 hours, but they are still on the higher end of the prices. And you have to buy each probe extra. You don't have a so easy portability of this. I mean, you can, but it's still a little bit bulky at the end of the day. And the internal storage is not as good. Then you have the handheld wireless devices. This is just an example of different of those. You have, of course, many different things like voice commands and AI, and you can connect those to the telephone and tablet. But those can be, again, as we have mentioned before, very bulky. Some of them really can fatigue your wrist. You have not so good battery running time, less than 1 hour. With some of those devices, you have to buy an extra fan in order to not make it overheat when you use it. And sometimes when you have this kind of devices, you have to update them frequently. And sometimes the moment you want to do your exam, then the next update comes, and then you don't have the possibility to use it for maybe 10 to 15 minutes sometimes. And they sometimes have also extra costs. Now, if we have a look into all of these things, those devices have some limitations in aesthetics. And this is actually what the finger probe is actually designed for ultrasound-guided injections, because we have, again, a curved line or a probe or a foot plate, I mean, and we have a lot of lightness in our hands. We are not using both hands or having even an assistant to help us. And this is actually the beauty of this new way to work with injectables, and not only fillers, but also, as I presented prior, botulinum toxin and even surgical indications. Now, with the finger probe, you have a great, powerful software and imaging. We have talked about this before. We have been improving, testing, and speaking with each other, between Ximena and many other people that have been involved. And of course, the IT team. It's just incredible how high the quality of this imaging tool is. And again, you will be able to do fine movements with your finger, use your hand, and adapt this probe to the concavities and convexities of the face, which is also one advantage. The precision and the control of the injection, I don't have to mention this because it's just clearly visible. And we have different variations. We have the portable mode that Hugues was presenting before. Now we have the all-in-one model, which is the one that I have been using lately, and I am really enjoying. this device, and you can have this one also in a trolley in order to make it even work more better. So the second point when you decide what to use are the probes, and the recommendations according to different international ultrasound groups is to use at least 50 megahertz, which we have with our probe. And we have here different linear probes, which again, you have to use with one hand. Now, the storage is also something very important. You need to keep those images in a safe manner, depending on how your country works or what is the recommendation. I recommend some high capacity external hard drives, or even that PAC system or a cloud system, which is the system that I use. And technical services and application specialist support. This is fundamental. If you buy a device somewhere else, very far away of your country, and you have a problem, then it's going to be very difficult to communicate with them, to even get a piece that you need to repair, or if there is just something that you need to know, sometimes it's pretty difficult to get someone on the other side. So it's very pivotal to have a technical service run on your side, in your country, in your city. And now my recommendations in order to give you something for your future. Just define your main goals with ultrasonography. Be clear of what you want to do, and just go and do a facial ultrasound training for beginners. Learn how to make the anatomy visible, learn the techniques, try different devices, and practice for 1 or 2 years. And then you are ready for the next step to do an advanced training. With this finger probe, we can actually even shorten more the learning curve, because we have seen that it goes actually pretty easy. And it's something about practice, practice, and practice. And at the end of the day, the best ultrasound that you can use or that you can have is the one that you use. That's actually my final word on this. And again, I thank you so much for your attention.
Thank you, Mauricio. Stay with us. We are going just to make some final comments and just a little conclusion. So, Hugues, many thanks to be with us for the conclusion. So, could we have just the last slide? And we are going, of course, to have more than 5 minutes to comment. So, it's important to begin by some important presentation about what now will be the main event for Europe. Welcome to the SibUS VIP class. We are going to organize with Hugues, with Mauricio, with Sebastien, with Audrey, and we are ready to welcome all of you guys. It will be May 24 from 9 a.m. to 3 to 4 p.m. And I think it's important that you understand that it will be totally dedicated to your practice. And we can tell you that after 1 day, you will be totally able to have quite an easy positioning and easy practicing concerning all you need concerning the application for this new method and this technology. So it's important to mention that the product now is ready to sell, and we can give you a nice attractive price concerning the introductory price we are going to have during this full day of training. And after this first day, I guarantee you that you will be on a nice level of understanding, full confidence concerning your practice with filler and toxin. And you will can evaluate what's the accuracy of this process and this method. And we have still a few spots. We are a little bit remaining. So we will be happy, of course, to have your visit. So please go to SibUS-In.com and secure your presence. If you begin to be our family, our networking, please assess all the service concerning SibUS Academy, who is totally dedicated to your practice and to have a very, very short learning curve adapted to this new method. So please explore www.SibUS-In.com Academy. And it's my pleasure to mention that now we are on this activity of distribution ready for you. And thanks to our big, fantastic, I would say, expert team, you recognize many of them, and I would like to thank all of them from Korea, from United States, from Europe, and from Latin America now. So please belong to this family. Just as a take-home message, I think we are before a major ultrasound-guided injection wave. There is no doubt about that. So you have not to be after the wave. You need to be prepared to this wave. From the blind injections that you have made during many, many years, now we have the live visualization during your injections. It's absolutely good, not only for your safety, but for your accuracy as well. And from the block hand injections, we came from, I would say, the generation of before. We have now the new gen, the finger probe injection. So it's not only a device, but you can easily assess that it's a real new method. So let's go to the class. Let's go to Bangkok. After the class, we are going to organize a nice hands-on ultrasound-guided injection SibUS class with Mauricio, with Hugues, and with many other Korean experts. We can, of course, invite you to this class. And in Paris will be a little bit later, just before IMCAS Paris. So we have time to mention that to all of you guys. So be connected. That's exactly what we would like. Please ask all the questions you would like. And it's a very good time now to go to your question, and we are going to answer to all of you. And just to finish, I think it's important, Mauricio, that you make a final comment. We are, in my opinion, before an important and absolutely with an evidence real wave. So what do you think? What would be in our future, very close future, our practice? Is it going to be with or without the probe? That's the point.
It's of course with the probe. The time has come now for having visibility, having accuracy, having effectivity, and the only way to go is using ultrasound. That's my final words.
And Hugues, what do you think about that? Do you think it's only, I would say, a trend? Is it only a marketing? Is it only destined to speak to a newspaper, or is it a real science? What's your point of view, Hugues?
For me, it's really science. And you know, it's not blind technique. You can see really what you see. And we cannot see so many patients we see today to use in a day practice ultrasound. The most important for us is maybe to use any ultrasound, okay, first.
Yes, absolutely. I think everybody needs to have his own assessment. Really, absolutely.
For safety, for the follow-up, so for accuracy, for the right plane of injection, toxin or fillers is so I can't say, I don't say any word to explain. Also, it's so easy. But I don't sleep with perhaps I sleep with my wife, but really in a daily practice, it's really convinced on. When I see some colleagues like Bertolt Razny, a professor of dermatology, he's listening to me, okay? And what he say, okay, the learning curve, okay, said, look at me, I'm dermatologist like you. I don't care about the best radiologist in the world. I want to check the product, to recognize the product, to see where is the muscle, the bone, the pattern, the vascular pattern. That's it. That's enough for me. On the probes, it's very easy to use in a daily practice. Really important for us. And for the science, you see, you can calculate, you can make the follow-up. We are surprising to see the disintegration of the product in time. It's so interesting for us. So if you want to be a doctor, to be more scientific, I don't say that if somebody don't use it, as a bad doctor. They do what you want. Exactly the same battle 20 years ago between cannula and needles. It was exactly the same. Do we use, remember, Benjamin?
And we have to present now to all our friends and colleagues the ecogenic needle.
Yes.
And that's something which is absolutely fantastic. We are going now to have the 30 gauge needle, 20 millimeters, then the 13 millimeter, of course, the 27 and the cannula. So it will be a real revolution. Yes. So Mauricio, in a few hours or days, I will be with you in Abu Dhabi. For
exactly.
AIDA and then the thinking class, and we are going to have, and it's our great pleasure, a nice class, a SibUS class, during May 3rd in Abu Dhabi, and then the same at the Conrad Hotel during May 4th and May 5th. So all of you guys, just assess, take your time, stay connected, and belong to this new family of SibUS. Stay connected.
Goodbye, everybody. Thank you so much.
Bye-bye.
Have fun.
Bye-bye.
Take care.
Bye-bye.
Bye. Nice
Safe.
to see you guys. Bye-bye.
Bye-bye.